Okay, great. Uh, Now, the question is, I think, how many attendees are we expecting? Should we give it some more time or should we go ahead and get started? What do you guys think?
I think
move we start.
everyone, we should go ahead and start. Yeah.
Yeah, because
Yeah,
yeah,
we're
people
about
will
7 minutes past.
as we speak. Yeah.
Okay. So I'd like to go ahead and start with an introduction of our guest speaker today. I'm very excited to have him. Dr. Paul Song is a board-certified radiation oncologist and co-founder and CEO of Fuse Biotherapeutics, which is a privately held biotechnology company focused on redirected immunotherapy in cancer. He last practiced full-time at Cedars-Sinai Medical Center. He currently volunteers at Dignity California Hospital, where he sees Medicaid and uninsured patients. Dr. Song served as the very first visiting fellow on healthcare policy in the California Department of Insurance in 2013. He graduated with honors from the University of Chicago and received his MD degree from George Washington University. He went on to do residency in radiation oncology at the University of Chicago, where he was also chief resident. And he did a brachytherapy fellowship in France at the Institut Gustave Roussy. I'm probably massacring the name. He was awarded an Astro Research Fellowship in 1995 for his research in radiation-inducible gene therapy. Dr. Song serves on the Board of Physicians for a national health program, the Pritzker School for Molecular Engineering, Progressive Democrats of America, and the Center for Health and Democracy. I'm honored to have him with us. It's a real treat, and thank you all for joining us. I'd like everyone to welcome Dr. Song. Thank you for being here, Dr. Song.
Well, again, thank you, Omer and Gustavo, for having me here today. I will say that my purpose of today's talk is really just to have a discussion. It's not to try to push any specific agenda down anyone's throats. I think clearly there are some I know that have tuned in that have their different opinions about what we as a nation should be doing on healthcare. My point is to try to share some of the facts that are out there, maybe find some areas where we can find common ground to work together, and then ultimately at least share with you why I think a single payer plan ultimately makes the most sense. There's going to be a lot of information that I'm going to share today that I will forward the slides on, and you guys can look at it. If you find anything that you disagree with, you can feel free to reach out to me. But really, I come with a real sense of respect for each of you, for your practices, and hopefully we can really just begin a nice discussion. So I'm just going to go ahead and share my slides. And can everyone see this here? Okay. So I graduated medical school in 1991. And when I did, C. Everett Koop was the Surgeon General, and he came and spoke at our school, asked us to raise our hands, and we all recited the Hippocratic Oath. I'm not sure if many of you remember your Hippocratic Oath, but there was one part of the Hippocratic Oath that stuck out to me, which was, I will follow that system of regimen, which according to my ability and judgment, I consider for the benefit of my patients, and abstain from whatever is deleterious and mischievous. And I would say that shortly thereafter, practicing as a radiation oncologist in Northern Virginia, I started to see glimpses of a system that was very deleterious to our patients and quite mischievous in terms of denying the proper care that many of my patients deserved. As many of you know, we spend a considerable amount on healthcare per person compared to the industrialized nation. But if you look at our life expectancy, we have less life expectancy. The other part that I think that we need to realize is, despite spending as much as we do per person, we have more people that are in financial ruin or face catastrophic healthcare spending as a result of their illness compared to any other industrialized nation. And the other part that I think that's staggering for us is the number of maternal deaths in the United States compared to many of our other modern countries, and the infant mortality rate as well. And particularly right now, as you have more and more states that are denying reproductive rights and demanding that women carry their pregnancies to term, and yet not giving them the proper resources, it's not unfathomable to see the maternal death rates actually continue to go up in the United States rather than go down. As an oncologist, as a radiation oncologist, I started at a time when there were no lifetime caps on treatment. And if you saw somebody with metastatic cancer who over the course of 5 to 10 years kept coming in for occasional palliative radiation, you would clearly see the financial toll that our healthcare system took on them and their illnesses took on them. Many of them were up against their lifetime caps. The insurance companies were not paying for the proper care that they needed. And it's no wonder that even today, even with the Affordable Care Act, that 1 out of 3 cancer patients have to turn their friends to family to pay for care, and debt and bankruptcy are still major things that are waiting for patients should they actually be cured of their cancer. It was during this time that I really wanted to learn more about what was wrong with our healthcare system. Up to this point, I had heard a little bit about single payer, heard a little bit about socialized medicine systems like the UK, and then really decided to devour literature, really go into it agnostically as if you were working up a differential diagnosis for one of your patients, and started to really not listen to what people said, but really look at the facts. And the issues that really stuck to me were the financial problems that continue to this day. Now, a lot of attention has been placed on the uninsured, but I want to focus for a minute on the insured. If you look at the number of people who get sick, who report using up almost all of their savings, it's roughly 2/3 of people, and these are people that have insurance. The number of people that have to borrow money from friends or family is roughly 40%. The number of people that have to pay for food or unable to pay for food, heater, housing is roughly 35%. How does that happen when insurance is designed to protect us from financial ruin when we get sick, that so many people face financial ruin as a result of their illness? And if you really want to break it down in terms of various ethnic communities, the number of people that have significant household debt, you can see particularly prevalent in the Black community as well as the Asian Latino communities. It still doesn't matter if you have a graduate degree or a high school diploma. There's still a large number of people that face financial difficulty and severe medical debt. And it's not really based on any geographic location. This is undiscriminating, but particularly hurts our communities of color. When people again look at who is having problems paying medical debt, sure, we can focus on the 34% of uninsured, but if you look at the number of people who get their coverage through employer-sponsored healthcare, this was the thing during the Democratic debate where you had Amy Klobuchar slam Bernie Sanders as saying, you're going to kick all these people off their employer-sponsored healthcare, but yet 40% of the people that get their coverage through their employer report having significant problems paying their medical bills. And this is the part that we need to really understand, that just because, quote, you get coverage through your job doesn't necessarily mean that coverage is going to really provide much. And then as far as what is the biggest amount of issues that are leading to the difficulty paying bills, it's primarily co-pays, deductibles, and co-insurance, which is really an insidious way of saying it's an additional tax or additional insurance on people. You pay these huge premiums, and yet when you get sick, you're being asked to pay a lot in terms of co-pays and deductibles. Sometimes it's going to an out-of-network provider. As many of you may know, the insurance companies have been very insidious in terms of having narrow networks. What that means is the number of doctors that you can see in your particular catchment area are generally less than 25% of all the available doctors in the area. So if you get sick or hurt in an accident, chances are you may get seen by a doctor that's, quote, not in the network. And these are some of the major problems that I think LACMA and CMA are right to address, but they need to continue to be really hammered home in Sacramento. The other part is during the last year, the California Health Care Foundation did a series of polls. They asked, have you postponed or skipped care due to cost? And in the state of California alone, 51% of people said that they postponed or skipped care. And of those, 41% said it made their overall condition worse. And again, this was disproportionately affecting communities of color. You see here that in terms of who skipped care, you had roughly 2/3 of the people of Asians, 40% of the Latino population, and again, roughly 60% of the African-American community all reported that they skipped care, but not to be undone, 53% of the white population also reported this. So this, again, cut across all ethnic groups. And then we also have this other major problem in our country, which is the long-term care crisis. Currently, 52% of adults reaching age 65 will require long-term assistance. We see more people with dementia, all sorts of issues where the families either have to give up working to try to care for them or try to put them in assisted living facilities. But as we all know, these are extremely expensive. My father-in-law was in one for roughly 2 years, and we were at the end paying almost $15,000 a month. And unfortunately, there's no end in sight for this problem. So it's no wonder that we as a nation believe that we are not getting good value for healthcare. Roughly 74% of all respondents think we're not getting what we pay for. The 25%, I'm curious to see what type of care they get. But overall, the majority of people now realize that we don't have a value-based system. So, you know, you're going to hear a lot of different things. I just want to clearly define what the various healthcare systems are. So single payer is not socialized medicine. We actually have socialized medicine in the United States. Socialized medicine is where the government owns and operates the hospitals, the pharmacies, the radiology department, the labs. They own and they employ every employee from the doctors to the radiology techs to the pharmacists. And we actually have that system in the UK, countries like Denmark, but we also have that here in the United States. The VA system is a socialized healthcare system, which ironically is taking care of people to defend our freedom. So whenever I hear people say that, you know, conflate socialized medicine, it's taking care of those people that fight frontline for our freedoms. The next is the employer-sponsored plan, which the majority of people get. Probably the closest to that is Germany's system. Then you have single-payer healthcare systems. Everyone likes to bash Canada, but I would tell you to look at Taiwan and Korea as much more successful models. Canada does not cover prescription drugs or tests largely, whereas Taiwan and Korea are much more comprehensive in the care that they provide for their citizens. And then we have a system of uninsured, which is like Myanmar and Burundi. But these are the various systems that are out there. So as you talk about systems, I think it's really important to understand the differences between each. And our country is made up of a hybrid of all these. We have a little bit of both. So in the run-up to the Affordable Care Act, I was frequently debating Ron Paul on Larry King Live about single-payer healthcare versus other systems. At the time, Ron Paul, who I have a lot of respect for, is a libertarian. I have a lot of libertarian friends, but he would say that a government plan would be a job killer, and what we need is less government and more freedom. So let's talk about that. The Heritage Foundation, which is a very conservative think tank, did a study of all the countries ranking economic freedom. And as you can see, all the countries ranked ahead of the United States. What do they have? They have a government-run healthcare system. And you can see they still have, quote, more economic freedom than we do here in the United States. With regard to the Affordable Care Act being a job killer, you can see that from the time that it was passed to right before the pandemic, we were on a record job creation. So all of those sort of lies that you always hear that a government-run plan is going to kill jobs or kill our economy are simply not true. And with regard to having a free market, I just want to point out that there is no free market in healthcare. There's only 2 industries in the United States that have antitrust exemption. It's Major League Baseball and the health insurance industry. And in major cities, it's usually the case where 1 or 2 insurers generally control 94 metropolitan areas in the United States. They have the majority of the subscribers, enrollees. And so the idea that you have the freedom to do things is completely not true. And let's talk about what's happened. So when you think about single payer, everyone's, oh, I don't want the government coming in and starting a single payer plan, but we are moving to single payer one way or another with all of the consolidation of insurance companies. You can see here that the 5 largest insurers in 2018 covered roughly 145 million enrollees, so roughly half of all the people in the United States. And you can see on the right of that how a lot of these insurance companies have slowly gobbled up regional networks and how they become stronger and stronger. And then on down below in the lower left-hand corner is the hospital consolidation. You're seeing fewer and fewer standalone hospitals. You're seeing Cedars expand down into the South Bay, down into Los Feliz. You're seeing Providence go from Newport Beach all the way up to Seattle. And it's no wonder on the right, when you look at the number of doctors that are able to be solo practitioners, why it's becoming fewer and fewer. It's hard for solo practitioners either to negotiate with insurance companies, to even get a contract, or let alone be able to be standalone in terms of having admitting privileges at some of the local hospitals. So I would say right now, it's a very, very difficult time for physicians to really hang your own shingle, to really be able to negotiate rates. And unless you are part of a large group to really withstand either the pressure of a hospital system or insurance companies, you are being pushed into sort of a lack of freedom practice. So also to point out that prior to the bailout, General Motors was paying more for healthcare costs per employee than it was for steel to build its cars. And it's no wonder that Charlie Munger said that medical costs are the tapeworm of American economic competitiveness. Our cockamamie system gives our companies big disadvantages in competing with other manufacturers. They've got single payer medicine and we're paying for it out of our own company. So as far as this term freedom, I would ask each of you to figure out how much freedom does the insurance company really give you? Generally, they tell you what other doctor you can refer your patient to, where you can send your patient to be admitted, where you can send your patient to have a test, and what drugs you can and can't prescribe. And Medicare does not tell you those things. Insurance companies will also tell patients where to go. They make the narrow choice of providers very, very limited. Just in the last 9 years alone, there have been 45 million denials here in the state of California by the largest insurers. And most people don't have freedom to move around their jobs because they're stuck in a job. Maybe they hate their job, but they're not leaving because of the healthcare benefits it provides. So the idea that somehow a government-run system would take away the freedom that we already don't have, I think is not fair. In the run-up to the Affordable Care Act, there were 3,300 registered healthcare lobbyists for the 535 members of Congress. In total, they were spending $1.2 million a day. More was spent lobbying Congress than what was spent on the Bush-Kerry election. And that's why the Lancet said the healthcare reform process exposes how corporate influence renders the US government incapable of making policy on the basis of evidence and the public interest. And that's why there was no public option, there was no insurance rate regulation, there was no drug pricing control. And so in the long run, all of these things really came back to hurt your patients and to hurt our overall practices. And what I mean by that is if you look at when the Affordable Care Act was placed into law to now, maybe they were able to, insurance companies weren't able to jack up premiums nearly to the degree they were, but what they did was they ended up making co-pays and deductibles greater. And then for those of you that have been getting your coverage through your employer, many people were asked to contribute more of their paycheck each month. So each month you had less take-home pay on the front end, but when you got sick, you ended up paying more in co-pays and deductibles. And this is just to show you that despite overall inflation and premiums and wages remaining stagnant, the premiums outstripped the amount of money that was being taken from paychecks was still greater, and especially look how much the deductibles really increased. And then 45 million Americans, this was in 2017, reported they couldn't fill a prescription because they couldn't afford it. And just until recently, the new bill that just passed yesterday now allows Medicare to negotiate drug prices. But prior to this point, 22% of seniors reported not filling a prescription because of cost. So hopefully we'll start to see some benefit. You know, when Kaiser uses its market share to negotiate drug discounts, it's considered good business, good free market. But when Medicare is trying to do it, it's considered government interference. And I just think that's completely hypocritical. And while we focus on insured and uninsured, let's not forget the underinsured, meaning that the paper that your insurance policy is printed on isn't worth any real protection when you get sick. It's estimated to be roughly 42% of all people that have insurance. When they get sick, it will not protect them from financial harm or ruin. So the other thing I just want to point out is how much COVID really exposed how broken our healthcare system is. We're now over 1 million deaths. A Lancet commission found that roughly 40% of all deaths in the United States could have been prevented. And part of that was because of the number of people that were uninsured. And they found that if everyone had insurance, it really would have greatly reduced the number of people that died. Also, just to point out that on the left, compared to every other industrialized nation, we had much, much higher deaths during the pandemic. And if you look at the number of communities of color that were disproportionately harmed from this, it really says a lot about the unequal nature of our healthcare system. The other part, again, was that during the Democratic debates, you had Amy Klobuchar say Bernie's bill would kick people off their millions off their employer-sponsored plan, but the pandemic did that. Here you can see roughly 14 million people lost their healthcare coverage when either they or their significant other lost their employer-sponsored healthcare. And then roughly 3 in 10 ran into significant problems once they lost their job that led to severe medical bills. So if you look at the loss of healthcare in other industrialized nations, you don't see people lose their healthcare with loss of jobs. So, you know, one of the things I think I would argue is healthcare should be a human right, not a job perk. I just want to focus a little bit on California and then kind of get to what a single payer plan is. So as many of you know, some of you are working frontline, taking care of our uninsured here in California. We have somewhere between 2.7 to 3 million uninsured right now. The majority of those are undocumented brothers and sisters. Some of them are eligible for Medi-Cal but have not registered. Some of them are here legal permanent residents but are not eligible for subsidies. But we have roughly 2.7 million uninsured here in California. And this was also a survey that came out in January 2021, showing what most Californians are worried about. And you can see the majority of people are worried about unexpected medical bills, out-of-pocket costs, and treatment for COVID. Rent or mortgage is lower down the list. Prescription drug costs are a little bit lower. So we do have a clear sense that the majority of people in California are really worried about how they're going to pay for their medical situation if they get sick. And then as far as what the views of California lawmakers should work on by party, 93% of Democrats report making healthcare more affordable, 82% of independents, and even 61% of Republicans. So this is a pretty much bipartisan issue. And then, so what has Gavin Newsom done, taking all of these into account? It seems like year after year, he and the legislature, all they seem to do is take more of our undocumented brothers and sisters and put them on Medi-Cal. The most recent is for Californians age 50 and older. We already had the young kids up to the age of 26. So each time we add more people to the Medi-Cal system, it may seem like it's a great thing and politicians may feel like they're doing something. But as many of you know, California's reimbursement for Medi-Cal is abysmal. We rank 48th out of 50 countries, 50 states in terms of the reimbursement on our Medicaid. And it's no wonder that back in 2013, for every 100,000 people on Medicaid, you could only find 59 full-time primary care physicians. And that number has now dropped even more. And so when you think about Medi-Cal, I would argue that, it's no wonder that more and more people, the LA Times has been doing a tremendous amount of stories on this, on the number of people that are the disproportionate amount of amputations that are occurring at MLK versus Cedars-Sinai, the disproportionate number of untreated diabetes. The number of people that have to wait longer. You can see that if you're less than 200% of the federal poverty line, you've had to wait 59%. They've had to wait much longer to see a doctor. And then if you look at the disparity in terms of, MLK, 94% of their hospital is people of color. Cedars-Sinai only has about 40%. Same thing with UCLA. And yet Medi-Cal patients make up 75% of the revenue at MLK, roughly 10% at Cedars-Sinai. And this was another story that the LA Times did, talking about how Medicaid patients suffer despite the fact that now a lot of it's been farmed out to private companies. It says, under this system, keeping patients as healthy as possible is one way to make money. Another is to deny or skimp on services. And yet we see the largest private insurers that are dealing with Medicaid are making record profits at the expense of narrowing the networks further for our citizens here in California. And it's no wonder that MALDEF sued the state of California, claiming that our Medi-Cal system was separate and unequal. And despite the state trying to block it, a judge ruled in favor of this moving forward, because it truly is an apartheid Medicaid unequal system. And when you just continue to put more people on the system, but don't improve the reimbursement, and you don't add more providers, you're further reducing the access to care. So I know LACMA and CMA have been fighting to improve the reimbursement, and I think this is one of the steps that everyone can agree on needs to be done to level the playing field a little bit more than what we have right now. So I'll spend the last 10 minutes talking about why are we spending so much and getting so little. Essentially, we have this very, very complicated, convoluted system. For those of you who have your own practice, maybe one year you're seeing somebody who has Aetna, and then they come back next year and then they have United Healthcare, and then a third year they have Medicare. Well, each time you've got to figure out what is their copay, what's their deductible, are you in their network, are you not? And all of the time that's being wasted on actual administrative elements and actually taking away from money that you could be using to reinvest in your practice is a big part of the inefficiency of our system, not just for you, but this is just to show you on the top, from 1970 to 2015, the number of doctors, the growth in doctors was roughly about 2 or 3%, but the number of healthcare administrators and managers, you can see, has gone over 3,000%. And down below, the curve sort of mimics when U.S. healthcare expenditures kind of took off. And I think this is not a coincidence. I think now that you have more administrative complexity and waste, it's making the system much more expensive and less efficient. In fact, Duke University has more billing clerks, twice as many billing clerks as it does hospital beds. And most hospitals use about 25% of their entire budget on administrative costs that instead should be going to pay for upgrades to ICU beds or ventilators or things of that nature. And it's no wonder that we spend more on administrative costs than any industrialized nation, and yet we spend less on long-term care per capita. So if we somehow could make our system more administratively efficient and maybe use some of that cost for other areas in healthcare, I think it would be something that would be very, very helpful. And it's no wonder that we've been ranked the least efficient healthcare system, and I know many of you feel this way. And this is probably some of you after a long day of taking care of patients where you are now being asked to churn them out, kind of like a cow pumping milk. And particularly if you're at a hospital that bought your practice and where you could spend time, now all of a sudden some administrators telling you, you need to ramp up your RVUs, or why aren't you billing more? And this is just to show you, this is from 2010, but I can tell you the numbers have probably gotten worse. This was the American Medical Association did a survey, and they found that the average physician spent 20 hours a week on pre-authorization. I know the CMA is trying to get Sacramento to pass a bill to do away with this, which I think is well needed. In general, 2012, the Kaiser Family Foundation found that roughly 868 million total hours were spent by physicians on prior authorization. The average physician in 2011 spent $83,000 hiring people to deal with insurance companies. And I'm sure many of you are spending far more than that now. And that's money, again, that's being taken away from actual building your practice, that's being many times spent on hiring people to get paid for things that you were well deserved to be paid for. So this is just to show you, again, some of the inefficiency that exists in our system. So if I had to just summarize problems with our healthcare system, we have roughly 31 million that are uninsured in the United States, 2.7 here in California. We have limited or no coverage for most undocumented outside California. And I can tell you the coverage here in California, the Medi-Cal system is really not good. We have no insurance rate regulation, no drug pricing controls. We have very narrow networks. Many of you were trying to get a contract from some of the biggest providers, probably that you can't even get them to talk to you unless you take Medicare or less than Medicare rates. As a patient, you see many more high copays and deductibles. We have a very high administrative waste and overall inefficient system. And again, lack of security with job security, employer-sponsored healthcare. So if I had to diagnose the problem, I would say one of the biggest problems is that we have this fragmented parasite that is taking actual money away from a system that otherwise is very complicated and convoluted. And just to show you that Medicare, despite taking care of sicker, older patients with more chronic conditions, that they have done a better job at controlling costs compared to the private insurance industry. So I would argue that instead of having this multi-tiered complexity, that it would be great if we had a universal single finance system. And I would argue that a single payer system is freedom. You would still be able to practice medicine the way you think is best. There would be far less paperwork and administrative costs. Companies would be freed from crippling healthcare costs, which would lead to higher wages, more capital investment, more job creation. Patients would have more freedom to choose their physician. There would be no more narrow networks, and patients wouldn't feel trapped in their current jobs due to the fear of losing their healthcare coverage. Now, one of the things that you'll hear is that Medicare for All would cost $32 trillion, and it would be so expensive. But it's funny, as much as Fox News was slamming this, Fox and Friends did a poll, and overwhelmingly people said they'd still be in favor of it. But let me set something straight. So the Mercatus Institute at George Mason University is a very conservative think tank, and they analyzed Bernie's bill. And they found that, yes, it was going to cost $32 trillion, but if we did absolutely nothing and continued the status quo, that would actually cost $2.1 trillion more over 10 years. So people don't really talk about that. They only talk about the cost of one, but they don't realize that if we do nothing, our healthcare system is going to be far more expensive, and we're still going to have roughly 31 million people uninsured. One of the other things you've heard is the public option. But again, this was defeated by the Partnership for America's Healthcare Future. They determined that a public option would add $700 billion to the federal deficit in the first 10 years. And a public option would not eliminate the problems that we have. It would add one more layer of complexity. It would not reduce the narrow networks or exclude it would still cause exclusion of our undocumented brothers and sisters, and it would not make our system more efficient in terms of reducing costs of premiums, drugs, or administrative waste. Finally, I just conclude with what the Healthy California for All Commission concluded. It was a commission that was set up by the governor. It had a lot of various stakeholders involved. I would say that the majority of the commission was not in favor of single payer. And the commission basically had a report that basically detailed the concept of unified financing as a statewide system to arrange, pay for, and assure healthcare in which all residents are entitled to receive a standard package of health services. They concluded that a unified system would not vary by age, employment, disability, income, immigration status, or other characteristics. And moreover, there would no longer be a distinction between Medicare and Medi-Cal or employer-sponsored coverage, and that individual coverage would be eliminated within a unified financing system. These were the recommendations and conclusions. And people ask, well, how can we pay for it? This was a study that was done from UCLA several years ago, but actually the amount of public funds actually account for more now than ever. And what they found was for every healthcare dollar spent here in the state of California, 70 cents of every healthcare dollar was already paid for us by the taxpayers, whether it was paying for healthcare for state workers, for our teachers, firefighters, whether it was giving tax breaks to Apple and Google to provide healthcare to their employees. We as a public were paying the majority of the healthcare spending in California. And when we talk about welfare, let's talk about corporate welfare. This is just showing you that of the top health insurers, 60% of their revenue already comes from Medicare or Medicaid, and that this has only continued to grow from 92 billion in 2010 to 213 billion in 2016, and I think it's even larger now. And just to point out that nearly 2/3 of people in the state of California do support a single government-run healthcare system, and that this is predominantly, well, actually, it's across all ethnic groups, and this is something that I think would democratize it, but certainly I think we're a long ways from this. And this was a study that Merit did with their physicians, that back early on, there was 2008, 42% of physicians supported a single payer healthcare plan, but then it now has increased to over 58%. I think this is generational. I think you're seeing younger doctors more in favor of this than certainly people have been practicing for a long time. But as somebody who has practiced now over 25 years, I can tell you this was not something I came to immediately, but just really became frustrated with every aspect of our system. I will just conclude by saying that my mom came here as an immigrant in 1951. She graduated from Columbia Teachers College, and the first person to hire her was Shirley Chisholm. Miss Chisholm ran a bunch of inner city preschools before she ran for Congress. In 1972, she then ran for president under the mantra of being unbought and unbossed. Unfortunately, we have too much of our Congress that is bought and bossed. But she said, "We have never seen health as a right. It has been conceived as a privilege available only to those who can afford it. This is the real reason the American healthcare system is in such a scandalous state." And I would argue that since 1972, we are now 50 years out. Our system is as scandalous as it ever was, and we still have many people that cannot get the care they need because they can't afford it. So I just wanted to at least share with you some of the facts. I went through things really fast, and I really appreciate your time. I'll make this deck available to anybody who wants it, and really appreciate the taking time. Thank you.
Great. Thank you very much, Dr. Song. That was a great overview and presentation and rationale for single payer as the best choice. Now I want to thank those of you who registered and submitted questions ahead of time, and also feel free to submit your questions through the chat. We'll be moderating those. I've already seen some really good ones coming in. Let me start off with a theme that has come up in some of the questions that were pre-submitted, Paul. One is that the opponents of single payer, obviously you highlighted very well, they have a self-interest in not changing the system because they're making a ton of money the way things are right now. And they have a playbook that says, you know, job killer, massive taxes, government run, program. What would be a reasonable pathway to get us to a point where not only the public, but the electorate will actually vote in that direction, but also educating our legislatures and other leaders? What would be a reasonable pathway that you would see to get us there?
So I got into a lot of trouble a couple years ago at a Bernie rally where I called out members of Congress, and I actually called out the Democratic members of Congress who claimed to be in favor of this, their constituents, but then always take money from various special interests and vote against their interests. I think we just have to continue to educate our patients, our neighbors, our communities on what a single payer plan is. It is not socialized medicine. It's not a government takeover, and really educate people on how little choices and things they have right now under the current system. And then you need to vote in people that are going to do the work of their constituents and not be beholden to the special interests. It's a challenge. I think the biggest reason we don't have single payer is not because of Republicans. It's actually because of Democrats. Remember when President Obama took over in 2008 and when after the Affordable Care Act, he had a supermajority in the House and Senate, and yet he couldn't even get the public option because you had too many people that were doing the work of the insurance industry or the pharmaceutical industry.
Yeah, thank you. And you touched on this earlier, and say you have a Medicare for all a model or a single payer sort of modeled after Medicare. Many questions came in saying Medicare has not kept up with practice costs, so we would obviously have to do a tweak. And then other questions mentioned if we do it right, it would include long-term care, dental services, durable medical equipment, things that people are having to pay out of pocket or forego. So how do we balance those two things? Is having a fair payment at the same time controlling the costs when we're adding more things?
So it's a great question, and I will say this: I don't think there's any perfect healthcare system. I have friends who practice in Korea. They were trained in the U.S. and they will tell you that they don't have certain drugs on formulary. Checkpoint inhibitors for cancer have been approved for second line, not first line. Although now they're starting to change it based on evidence-based decisions. But I will tell you that the idea that we have a system that works right now is simply not true. And what I'm looking at in terms of nobody goes bankrupt in these countries when they get sick. Nobody's denied care. I will say that it is one of those things where I think everyone needs to afford a decent basic package that currently not everyone gets, where they don't have huge out-of-pocket costs. And then afterwards, if we can afford long-term care or subsidy towards long-term care, then we can at least go through that. What I'm just trying to say is that let's try to get everyone to some basic human decency in terms of their healthcare, that they can go see anybody. They can see any of you now. I guarantee there are a lot of patients out there that even if they wanted to come to see you, their plans don't allow them to go to see you. Wouldn't it be nice if they could go to anybody and not be dictated by the private insurance industry? Now, the other thing I know that people are worried about reimbursement. I can tell you that when I was working as a radiation oncologist, I moved here from from Virginia, where some of our contracts were getting 1.6 to 2 times Medicare, which is unheard of. And I came out here, and then all of a sudden I joined a practice and they said, oh, we're lucky if we get 1.2 of Medicare. And then there were some other contracts that came in and they wanted us to take less than Medicare. And I guarantee for all of you that are using the boogeyman, well, Medicare is so bad, at some point, these private insurance industries are going to make you take Medicare or less than Medicare. And on top of that, the amount of money you waste fighting with them on pre-authorizations or denials or any of those things are only going to make that reimbursement even less than what you get right now. If you did away with that administrative complexity and you got a good rate, and then as a result, you didn't have to spend all your time on paperwork or fighting insurance companies, and you could see an extra 10, 15% more patients a day, but still not feel burned out. I think we all would feel that would be a good trade-off. But again, I'm not saying there aren't things that have to be worked out. I think what I would say is you have no negotiating power right now with the insurance industry. at least I would think the AMA and the CMA would have some seat at the table to negotiate rates, but eliminate a lot of the administrative headaches that we're all dealing with right now.
That's a great response. And I see Dr. Deen has a question, but let me just ask a follow-up here that came up through the chat and in our previous questions. And that is that if we have Medicare for all and we get the rates just right, and they have a escalator for unanticipated costs, the temptation from our electeds, Congress, et cetera, would be to start balancing their budgets on the backs of healthcare, right? And that the inevitable ratcheting down of payments is likely to happen, where we could eventually get then Medi-Cal for all, to at some point. How do we protect against that?
So I would just say, look at the way the government is working. The only people I see ratcheted down under the current system is physician reimbursement. I don't see the payments to insurance companies. As I mentioned, 60% of insurance revenue is coming from the government. I don't see ratcheted down reimbursements to the hospitals. So, again, I think that the administrative savings that would be gained from this and then the increased care and coverage that every patient would have. I don't know if some of you, if you were only focused on getting coverage from, like one payer group, but I would say for those of you that see mixed payers, you're probably, and those of you that are willing to see sort of the bottom feeder insurers, you would actually maybe come out ahead under a new plan. Now, if you've got a practice where you can pick and choose who you want to see, I could see where maybe you don't think this would work for you. One of the things I would say is that I'm really focused on the remaining 90% of the physicians that currently are in a system that's not working for them right now. Physician burnout is real. The amount of hours you're spending. I know the reason I left Cedars was I got tired of, case manager, yelling at me for not billing something that I normally wouldn't bill for in my regular practice, just because I thought it was common courtesy. And the amount of time that you put into Epic, which is designed to generate maximum profit for a facility, not so much to make our lives more efficient. All of those things are things that you have to take into consideration.
Great. Dr. Deen, did you have a question or a comment?
I agree with what you're saying. And as somebody who's in, one of the few left here in solo private practice, I have my own biller. I'm dealing with all these payers and trying to negotiate rates. It's true that we have competition right now with several payers as opposed to a single payer. But I can tell you 100%, they are competing to see who can pay us the least. They're not competing to see who can pay us the most. We're complaining about Medicare rates, and everybody will say, Medicare at least pays better than a lot of these other payers. But it's getting increasingly difficult to keep our heads above water. Anyone that feels that we would be losing competition by doing this, I encourage them to kind of look through these numbers again.
I would really ask each of you to look at your reimbursement over the last few years from the largest insurers, and the percent decrease overall compared to, and then look at your administrative waste that you've had to spend on that, fighting the number of hours. I know I found it really awful. You'd spend time fighting for something that you were approved to do, and then they were taking time to pay you. And the amount of time you had to fight just to get paid what you were due, that doesn't happen in other systems.
One of the questions from the chat relates to the social drivers of health. There's a Commonwealth study that came out a couple of years ago that looked at European nations, and for every dollar they spend on healthcare, they spend $2 on social services, the upstream prevention of many of the medical costs. And looking at the US, for every dollar we spend on healthcare, we only spend 25 cents on social services. So how do you see coupling those in the future, and what would it take to actually bring them together?
Well, I think it's really important, right? So part of the reason I think COVID disproportionately affected communities of color is because of the uncontrolled health conditions in those communities to begin with. Many of them had breathing issues because of the pollutants that were in the air next to them, these social determinants of health. Many of them were in food deserts, so they didn't have access to proper nutritional food, and a lot of them either had uncontrolled diabetes or obesity, things of that nature that again made you more susceptible if you got COVID. And then on top of that, many of them were frontline workers that didn't have insurance. So I think it's all tied in. One thing I will just say about Medicare is right now it's only taking care of the oldest, sickest people in our country. You know, the private insurance industry has gamed the system. We're just going to cover people to about 65. And then when the risk pool gets too great, we'll just turn them over to the government. And occasionally they'll cherry pick seniors based on whether or not they belong to a health club and all those things. But the idea is that under one system, all of us who, if those of you who are in your 30s, those of you, your kids, they would all be in the system. So with the money that would otherwise go to the private insurance industry for that would all go into a pool to strengthen the pool. When you hear Medicare is going broke, imagine if you started to enroll everyone under the age of 20 to 40, the quote low risk population, and they're paying premiums into it. Well, it's going to strengthen Medicare, and ultimately there'll be more money in there to perhaps provide better reimbursement and things of that nature. And because you're taking care of the whole society versus just the sickest of the sick, maybe there will be an opportunity to negotiate better rates. Certainly, these are the things that people have to understand. Why, Medicare got stuck holding the end of life sickest of sick patients, and yet it does a better job of controlling outcomes and costs.
Absolutely. There's a couple of really useful links that Dr. Anna Yap put on the chat room on the Medicare ratcheting and AMA's piece on the same topic. One of the other things.
Can I say something about that, Hector? Though.
Yes, please.
If you don't think the private insurance industry is rationing care, I think then I'm not sure which patient population you guys have been taking care of. I can tell you, going from Cedars, and part of the reason I started to volunteer California Dignity is I'd see somebody that came in through the emergency room at Cedars with a big 10-centimeter bleeding cervix mass, and have to stabilize them. But then as soon as I stabilized them, we don't participate in that. Then they get transferred to California Dignity Hospital. And because I started to see those, I was like, who's this person taking care of patients? And then I started to go down there. I can tell you that Medicaid and the private insurance industry is rationing care all the time. We need to get behind, we're going to start saying things about Medicare, look no further than the private insurance industry in terms of what they're doing.
Yeah, that's a great point. And, to close, Benjamin Franklin was said to have said that our democracy is doomed when people figure out how to vote themselves money. And you had a slide earlier where it's not only the insurance companies, but also hospital systems. They know how to line their pocket, and then also big pharma, of course. And what happens is when those costs keep going up uncontrolled because they have the lobbying power, the ratcheting comes up upon the doctors. And that was a couple of the comments also made by our registrants. Well, we're at the end of our time. As usual, we could go on for hours, Dr. Song. You're a wonderful speaker and you're great encyclopedic knowledge on this issue. Just a couple of reminders. If you're interested in CME, we will be sending you out a link. Just a reminder that there were no commercial interests in this program or any conflicts of interest. And we have additional questions. One of the questions came up, if you be interested, if we sent you the questions, Dr. Song, that came up through the chat, maybe you could answer a couple of those remotely through email.
Yeah. Let me give everyone my email. It's paulysong@gmail.com. And just to say this, I know some of you on this, I disagree with me, probably even vehemently, and I will just say I respect you all. I appreciate you all at least listening, and hopefully we can find other things to work together on, such as, again, improving reimbursement for Medi-Cal, or perhaps even rolling Medi-Cal into a Medicare system. The pre-authorizations, I think, clearly are destroying our ability to practice. And I think there are areas that, listen, I agree with you. I appreciate the work LACMA is doing and want to find common ground. But I do appreciate you taking time to listen.
Thank you so much. Dr. Deen, you want to close us off?
Yeah, I appreciate that. Paul, thank you so much for being here and for sharing your knowledge with us. Everyone who's on this call, thank you for those thoughtful questions and for tuning in. I think this is a discussion that whether we want to or not, we're going to be having moving forward. Dr. Song, I'd appreciate continued collaboration between you, LACMA, and CMA. I think that if we can all have a seat at the table and be a part of this discussion, hopefully we can at least improve upon the system, even if we don't reach that utopia that we feel we deserve.
I look forward to working with you guys. I think there are a lot of things we can do in the short term. I don't think single payer is going to happen in the immediate, not under the political landscape, but things that we can work together on. I'm here to work with you all.
Appreciate that.
Again, Dr. Song. Appreciate it very much. And thank you everyone for joining us this evening. Appreciate your
Thanks everyone. Have a great night.
Thank you.
Thank you.